Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B or C which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. Now read the question.
A thyroid scan provides information about your thyroid size, shape, and position. During a thyroid scan, a radioactive material called a radiotracer is swallowed and is absorbed by your body. It travels through the area being examined and gives off energy in the form of gamma rays, which are detected by a special camera and computer to create images of your thyroid. A thyroid scan tests your thyroid's function. It measures how much radioactive iodine is taken up by your thyroid in a given period of time. You will be given the radioactive iodine in liquid or capsule form. During the exam, you will sit in a chair and a probe will be positioned over your thyroid while a scanner moves over your neck. To prepare for these tests, you may be asked not to eat or drink anything and to refrain from taking certain medications beforehand. Leave any jewelry at home and wear loose, comfortable clothing. You may be asked to wear a gown. Tell your doctor if there's any possibility you are pregnant or if you're breastfeeding. Discuss any recent illnesses or other medical conditions, medications you're taking, and whether you have any allergies. Also, tell your doctor if you've had any procedures within the last 2 months that used iodine-based contrast material. You may have some concerns about thyroid scan and uptake. However, because the amount of radiotracer used is small, the level of radiation exposure is relatively low, and the benefit of an accurate diagnosis far outweighs any risk.
Question 26. Now read the question.
At a hospital discharge meeting, the patient would meet with the nurse, the physiotherapist and the pharmacist on the ward. The nurse would go through all the information the patient would need to go home, and often relatives are invited to come along to listen to the information as well. The nurse would talk about managing wounds at home, looking after the wounds, making sure they remain clean and dry, looking out for signs of infection, for example redness or swelling, or if the wounds become oozy. And if anything of those happens, the nurse would advise the patient to go and see their GP straight away. The nurse would also talk about the rehabilitation process and would include information about dietary concerns, exercise and smoking cessation if the patient is still smoking. The physiotherapist would talk about exercises the patient needs to do following the surgery. It's really important for the patients to get up and mobilise around, and the physiotherapist would give some exercises for the patient to do every day, and would encourage the patient to walk as much as possible and build up the walking time each day with their relatives. The pharmacist would talk about the tablets that the patient's going to be on following their surgery. Often tablets change whilst the patient's in surgery, and the pharmacist would talk about the tablets, explain the side effects, any issues related to those tablets, and would explain when to take the tablets as well. And those tablets normally would be reviewed in the outpatient clinic post-cardiac surgery to see if they are still needed.
Question 27. Now read the question.
Today I'm going to be talking about a BiAmp overhead paging system along with a Rollin-Borg nurse call system and the power of connecting those two together. We can automate code blue processes so that when a code blue is pressed, it can automate a response overhead to the paging system, which I'll demonstrate right now.
Attention. Code blue. Room 501. Medical ICU.
Okay, now the power of this is that, like it said, medical ICU right there, we can add any suffix we want onto that and give clear delineation on where the code blue is coming from and where the staff needs to go to respond to that code. I can make it repeat. We can add different preambles, as you heard a preamble before that. It is really a powerful tool, and I'd love to talk to you about it.
Question 28. Now read the question.
Today I am answering a question about preschool stuttering. So how long do we wait? Well, Mark Onslow of the Australian Stuttering Research Centre recommends that a speech therapist should monitor a child for signs of natural recovery for about 6 months, but no longer. So that's his recommendation. He also explains that there are other reasons that you may want to begin therapy sooner, and that would be if the child becomes distressed about the stuttering, you want to go ahead and address it at that point because psychological damage could start to happen. Also, if the stuttering is causing social problems or psychological issues. So if it's interfering with social interactions or any of that kind of stuff, you definitely want to go ahead and address it sooner than that 6 months. So that being said, what do we do? How do we go about fixing stuttering in preschoolers? Well, although there have been many different types of stuttering therapy over the years, there was a systematic review in 2006 by Booth and all of his or her associates. I can't remember if that's a woman or a man. And that study found that the response contingency approach was the most effective treatment for children who stutter. So if you would like to find out more about the response contingency approach, you can click on this link down here. It should be in the show notes right below this video. It's speechandlanguagekids.com/stop stuttering preschoolers current research-based methods with dashes in between all of that. So just go down there and click the link. And that will take you to my page all about response contingency stuttering therapy. There's a video that explains it and demonstrates it. So head on over there and check that out. If you have any further questions, please leave those below and I'll get back to you as soon as possible. Thanks so much and have a great day.
Question 29. Now read the question.
First and foremost, I think 20 is the new 25. When we studied glaucoma in school, most people were under the impression that 25 millimeters of mercury was the high end of normal. We've found that recently, at 20 millimeters of mercury, the intraocular pressure is elevated enough to be adequate, but at 25, it's really starting to affect axoplasmic flow on the optic nerve. So really aim for a pressure of 20 in your veterinary patients. Other things that are new in the realm of glaucoma and pets include the realm of neuroprotection, so medications like memantine, timolol, bimatoprost, and minocycline, which may actually protect the nerve and the nerve function. We are starting to look at glaucoma as more of a neurodegenerative disease, so not only a disease of the eye, but also a disease of the brain, and it can actually be affected by systolic blood pressure as well as intracranial pressure.
Question 30. Now read the question.
The goal of this paper, this health policy statement, is to give a uniform document where all laboratories can find the information they need and utilize that information to communicate in all aspects of healthcare to improve patient quality. I've had the experience over my career through SCI, working on the quality committee, through the accreditation committee and ACE, and through lab surveys committees, to see there's significant variation in all laboratories with amongst multiple laboratories about the catheterization labs. Some using pros, some using documentation, some multiple entries for billing and inventory and databases, and every different entry has the potential of an error. The goal of this report is to take that potential error out of it and improve patient quality. The emphasis that we had throughout this effort was to make this as uniform for the laboratories, for the vendors, for all to make it easy to transfer data, to make it non-repetitive, and have a uniformity across all fields.
That is the end of Part B. Now look at Part C.